or whatever.
So thank you, Angela, for being interviewed today. Angela works as a pharmacist with us in Timber Creek, which is a chronic care facility in Surrey. So Angela, I have a few specific questions in relation to obsessive compulsive disorder. And we're not talking about any comorbidities, specifically only obsessive compulsive disorder. What are the first line treatments from pharmacological perspective in obsessive compulsive disorder?
First line treatment are SSRIs. The medication that have evidence include fluvoxamine, paroxetine, sertraline, escitalopram.
Okay. And what kind of medicines that we typically use in other anxiety disorders and mood disorders, which have no evidence base in O.C.D, so that we don't prescribe it for the clients who have obsessive compulsive disorder?
Yeah. The only medication that have evidence from the TCA is clomipramine, which is a second line for OCD. The other TCA has no evidence, and lithium, ECT, clonidine, risperidone all have no evidence.
What about benzodiazepines?
They don't have any role in OCD treatment.
Okay. Any role for ECT?
ECT, no.
Okay, and lithium?
Yeah, no.
No role for that. Okay. Then there is this concept that we need to use higher doses in obsessive compulsive disorder. So what is your understanding that is it must for the client to go on a higher dose when they have the diagnosis of obsessive compulsive disorder?
This is a controversy issues. From the studies, it shows that fluvoxetine up to 40 milligram a day is beneficial for patients, but there is no specific recommendation for individual SSI. What is the maximum dose recommended? It's really based on the tolerability issue for the patient. If the patient can tolerate a higher dose, then you can go slightly higher than the recommend usual dose for the SSRI. But if they start developing symptoms such as sweating, diarrhea, tachycardia, high blood pressure, and muscle stiffness, then you need to cut down back the dose to or like cut, because the more side effect they experience, they are less likely to take the medication.
Okay. As a family physician, what are the main things that I need to look at if I'm prescribing clients SSRIs at a higher doses? What are the things that I should be careful about?
Yeah, like the serotonin syndrome that I mentioned about, and also sometimes SSRI may reduce sodium levels, so you may want to check the electrolytes when you're starting on someone with an SSRI. And then specifically, escitalopram have a higher risk of QTc prolongation, so ECG may be beneficial.
Okay. If I am treating a client with SSRIs and they are not responding or they start having side effects, so when is the time to think about augmentation strategies? And what kind of treatment has the most evidence?
Yeah, like sexual dysfunction, I didn't mention earlier, is also a very prominent side effect of SSRI. So if the patient cannot tolerate any of these side effects, or if they have a cardiac history, which clomipramine may not be the most ideal medication to use, then you can use the lowest, the highest tolerable dose for the SSRI, and then add an augmenting agent, which is an atypical antipsychotic. The ones that have evidence are aripiprazole and risperidone.
Okay. Thank you, Angela, for this. Appreciate your help.
Thank you.